Welcome. My name is Dr. Mindy Christensen, and I am the director of the Cleveland Clinic Fertility Center. I'm going to serve as our moderator today. On behalf of the Cleveland Clinic Breast Cancer Program, welcome to this recorded educational session regarding pregnancy-associated breast cancer. Although this is an uncommon condition, the care for pregnant women who also have a new cancer diagnosis is nuanced, and it requires a multidisciplinary team of experts. Here at Cleveland Clinic, we are very lucky to have these specialists here on staff. Some of them are joining me today. So allow me to introduce Dr. Erin Rush, breast medical oncologist, Dr. Catherine Singh, maternal fetal medicine expert, and Dr. Stephanie Valente, breast surgical oncologist. Dr. Rush, what is pregnancy-associated breast cancer and how often does it occur?
So pregnancy-associated breast cancer is defined as breast cancer diagnosed during pregnancy or up to 1 year after delivery. For the purposes of today, I believe we'll be focused on those women diagnosed with breast cancer during their pregnancy. This is an uncommon diagnosis occurring about 1 in 3,000 pregnancies.
Are there any specific risk factors for pregnancy-associated breast cancer?
So the hormonal changes that occur during pregnancy and lactation, as well as breast changes that occur, have thought to be associated with breast cancer diagnosed during pregnancy. Additionally, we also know about other historical risk factors such as genetics, family history, and other reproductive factors.
Dr. Valente, what should a woman do if she discovers a breast lump when she's pregnant?
A breast lump during pregnancy can be a lot of things. Most of the time it is benign, and it's difficult because a woman is experiencing a lot of changes in her body and her breast is just one of them. But any new lump or bump should definitely be brought to the attention of her physician. And what's safe and easy is to do a breast ultrasound. There's no radiation, but if the ultrasound looks like it could be a suspicious mass, specifically cancer, then a formal mammogram can be done and the fetus could be shielded, but definitely something to get looked at. So I usually tell patients, if there's a mass that's been there for more than 2 weeks, they'd need to get it checked out.
After a woman has a confirmed diagnosis of breast cancer, what are her treatment options during pregnancy? We'll start with you, Dr. Valente.
Sure. So a newly diagnosed breast cancer patient will meet with a surgeon. She'll also meet with the medical oncologist, the radiation oncologist, and a high-risk maternal fetal medicine physician if they're available. The first thing we talk about is whether or not surgery first to remove the cancer is the best thing to do. We also need to look at the time of her pregnancy, what trimester she's in, because certain recommendations are given or not options based on the trimester. So a lot of times the first trimester, up to about 14 weeks, is where we want to avoid any type of chemotherapy, only if it's recommended. We really kind of want to delay surgery if we can, but surgery definitely is possible during the first trimester. Surgery is a possibility at any stage for any woman. And then kind of looking at whether or not they need additional therapy after and what that time is. So it's great to meet with a multidisciplinary team and have those discussions up front so that we're all on the same page. Similar to anybody with breast cancer, a woman that's pregnant has options that are very similar as far as surgery. So, we talk about breast conserving surgery, which is a lumpectomy. Usually after that, they need radiation. So again, we just have to look at timing to make sure that they can get radiation after they safely deliver. Radiation for a lumpectomy is traditionally not recommended. For advanced cancers, we can give radiation for different things, but traditionally not for breast-conserving surgery. Mastectomies versus going flat versus reconstruction is definitely still an option for pregnant patients, and so we would pull in a reconstruction surgeon at that time. And then, how do we manage lymph nodes and whether or not the cancer is spread there? So it's a really good discussion, and just knowing that monitoring the patient and her baby during surgery is very important. So a lot of times we'll pull in the maternal fetal medicine physician. What do you want to say about that, Dr. Singh?
Yeah, I think that the team approach here is key, like having a good group of physicians that a patient can work with, having us have the ability to talk to each other. And then, of course, the most important part of all of this is the patient's decision in what, the patient's comfortable with, what treatments, So I think it really, in a perfect scenario, is like a group discussion. And then, for the pregnancy, I think so many people assume that the cancer won't be treated during the pregnancy. And, Dr. Resch will go into this a little bit more, but there are so many options. And the OB team, the maternal fetal medicine team, really helps to support the, patient along the way and monitor the baby throughout this process.
And then from the standpoint of medical therapy during pregnancy, so we'll talk about, for example, chemotherapy. So chemotherapy, certain chemotherapy drugs after the first trimester have demonstrated relative safety during pregnancy. So that is a possibility depending on the situation. Hormonal therapy or endocrine therapy is not recommended during pregnancy. And again, I think that timing is really critical here. I'll sit down with a calendar and actually look through, a woman's, gestational age and then when they are planned to deliver, and when we're timing things such as their chemotherapy to make sure that it's being done in a safe fashion.
Dr. Singh, what effects do cancer treatments have on the baby?
Yeah, that's an excellent question. I think that's a natural question that all pregnant women with pregnancy-associated breast cancer often ask us. Obviously, any sort of cancer treatment that could affect the mother could have some small effects on the baby. But as Dr. Resch mentioned, we try to tailor the therapy to have maximal maternal and safety for the baby as well. And so we look at the whole picture when making these decisions about what treatment should be started.
How do you monitor the baby during treatment?
Yes, I mean, the first rule is also to monitor the mother, looking at maternal nutrition, looking at mental health, looking at the whole picture is number one. The healthier the mother is, the healthier the baby can be. And then we'll often do, extra ultrasound monitoring of, the baby's anatomy, of the baby's growth curve, of the baby's well-being, depending on the situation. And so there is some extra monitoring that I think most OBGYNs and maternal fetal medicine doctors will recommend, more to be on the safe side.
And then when it comes to the delivery, are there any special considerations?
Yeah, that's a really important point. I think this is where the team approach becomes really key. Making sure that the delivery is timed at a time when basically certain medications maybe are at maximal effect is really important. I don't know if you want to elaborate.
Yeah, I completely agree. So I mentioned chemotherapy during pregnancy earlier, and it's important, again, timing is critical. So in this regard, finishing chemotherapy early enough prior to delivery to maximize the safety of both the mom and the baby.
So what about post-delivery? Tell our audience a little bit about that.
I think the first thing is that in most situations, we really strive to get a full-term baby. That makes all the difference in the world for neonatal outcomes, for maternal and baby bonding. Being able to get to full term is definitely a goal. And most of the time, with the timing of any treatments, we can make that happen. In addition, we don't usually change how a patient delivers based on breast cancer or therapies. And so hopefully the recovery wouldn't be necessarily changed by having breast cancer. And so hopefully mom is doing well and baby's doing well, and they, can bond and have a somewhat normal newborn mother bonding experience.
Yeah, and then when it comes to the medical therapy for breast cancer after delivery, it's important to talk with and communicate with the patient's OB about timing of either whether it's initiating or resuming any chemotherapy or starting endocrine therapy in the appropriate situation. So again, open lines of communication and looking at the woman's recovery.
Dr. Valente, what about breastfeeding? What role does that play?
Sure. So in women who still have a breast, so patients who underwent breast conserving surgery, they're able to breastfeed, especially colostrum is really important in that newborn period. So they're able to breastfeed until they need to resume therapy, such as any medical therapy, or if radiation is recommended. It usually starts, a few weeks after they deliver, so they've got that time, and they can always breastfeed from the non-affected breast.
Finally, for each of you, what advice do you have for pregnant patients undergoing treatment?
Yeah, so I think key to engage all of your providers and really, find a team that you feel comfortable with and ask the questions, be an advocate for yourself. It's a really challenging and emotional time for women to be dealing with a diagnosis of breast cancer and also pregnancy, but we can expect really great outcomes as well with appropriate treatment. So I think I would remember that positive note.
I think it's really important to remember also, developing, a lot of social support, whether that's family, friends, not only, the cancer journey during pregnancy, but just any postpartum patient. That's a really challenging time, and making sure that you have a lot of resources set up around you, I think is really, really important.
Women are tough. Moms are even tougher. You think having a baby and being pregnant is difficult, and then you add cancer on top of it and having to undergo surgery and treatment. And so I think, the thing that we tell patients is, there is life after cancer where you're going to be able to enjoy your baby and your kids. And so that's kind of the motivation to get women to move forward during this time.
Thank you for joining us today to discuss pregnancy-associated breast cancer. Everything you shared was so useful, and I'm sure our audience will really find it very useful as well. Thank you for joining us in this insightful discussion on the multidisciplinary management of pregnancy-associated breast cancer. We hope the information shared by our panel of experts has provided you with a deeper understanding of the complexities and considerations involved in managing breast cancer during pregnancy. Remember, the collaboration of a multidisciplinary team is crucial in ensuring the best possible outcomes for both the mother and the baby. To connect with the breast cancer team at the Cleveland Clinic, please call 866-223-8100. That's 866-223-8100. You can also visit our website at clevelandclinic.org/breastcancer. That's clevelandclinic.org/breastcancer.